Sudden cardiac death remains a major cause of the death in industrialized world. Implantable cardioverter-defibrillators have been shown to be an effective therapy option for the primary prevention of sudden cardiac death in patients with high risk of it. About 60% of implantable cardioverter-defibrillators are implanted for primary prevention, the remaining for the secondary prevention. The treatment of patients largely depends on age, comorbidities and reason for the implantation, primary or secondary prevention. The next report will be about safety and tolerability of implanted subcutaneous cardioverter-defibrillator system. Dear Anna Vereshchagina, the floor is yours.
Good day, esteemed colleague. Allow me to present to your attention our works on safety and tolerability of implanted subcutaneous cardioverter-defibrillator systems. Sudden cardiac death is the leading cause of mortality in the population. Various electrophysiological mechanisms may underlie the development of sudden cardiac death. Analysis of electrocardiograms recorded during out-of-hospital cardiac arrest most frequently reveals life-threatening tachyarrhythmias such as ventricular fibrillation and high-frequency ventricular tachycardia. The pharmacological treatment of these rhythm disturbances is limited. Currently, implantable cardioverter-defibrillators are the primary method for preventing and treating SCD. However, complications associated with transvenous ICD electrodes significantly increase morbidity and mortality in patients. To overcome the limitation of transvenous ICD since 2015, the subcutaneous implantable cardioverter-defibrillator, a fully extrathoracic device consisting of a pulse generator and single subcutaneous defibrillation lead, has been introduced into clinical practice in 2022. The European Society of Cardiology recommended subcutaneous ICD as an alternative of transvenous ICD for patients without indications for pacing, resynchronization, or anti-tachycardia therapies with a Class 2A indication. The subcutaneous ICD is emerging as a promising technology, increasingly preferred for patients requiring ICD implantation. By the end of 2022, more than 88,000 devices had been implanted worldwide. In the Russian Federation, the implantation of subcutaneous ICD began in 2020. To date, about 150 devices have been implanted, with most procedures conducted at the National Medical Research Center of Cardiology, named after E. Chazov. Literature on the use of subcutaneous ICD in our country is limited. Large international studies on subcutaneous devices have included patients indicated for both secondary and primary prevention of SCD. However, it's believed that patients indicated for ICD implantation for secondary prevention of SCD more often develop monomorphic VT, which can be terminated by anti-tachycardia pacing, a feature not available in subcutaneous ICD. The only direct comparison of subcutaneous and transvenous ICD was also conducted among patients indicated for both secondary and primary prevention. Therefore, studying the use of subcutaneous ICD subcutaneous ICD and transvenous ICD was also conducted among patients both secondary and primary preventions. Therefore, studying the use of subcutaneous ICD exclusively in patients with primary prevention of SCD. For this prospective study, patients were selected according to the inclusion and exclusion criteria. In this slide, you can see inclusion and exclusion criteria. An important step in the implantation of subcutaneous ICD in the pre-implantation screening, 131 patients, candidates for cardioverter-defibrillation implantation, underwent screening. 14 people did not pass the screening and were excluded from the study. Patients requiring resynchronization and anti-tachycardia therapy and those who required ICD implantation as a secondary prevention measure were also excluded. 95 patients were subsequently divided into two groups. 52 people were included in the subcutaneous device group, 43 were implanted with transvenous ICD. Patients were assessed at the 6 and 12 months. To ensure individual efficacy of subcutaneous ICD for specific patients, a pre-implantation screening of the electrocardiographic patterns is recommended. During screening, the position of the sensing electrodes or pulse generation is simulated to assess the accurate reading of the defibrillator ECG signals. The segments between the red, yellow, and green electrodes mimic the free vectors of subcutaneous signal perception. Arrhythmia detection is carried out using all the free vector format between the three sensitive poles of the system. This consists of the primary, secondary, and alternative vectors. The pulse generation is the area of the 5th to the 6th intercostal space between the left anterior and middle axial line. The device is large when transvenous ICD, weighing about twice as much, 145 grams. The generator can deliver up to 5 high-energy, non-programmable defibrillation impulses per episode and anti-bradycardia pacing at a rate of 50 beats per minute for 50 seconds. In more than 3.5 seconds of post-shock assistance is detected. The estimated lifespan of the third-generation subcutaneous ICD was 5 years, while of the latest models it exceeds 7 years. Furthermore, remote monitoring of the device is now available for the new model of subcutaneous ICD. Patients are considered suitable for implantation of the subcutaneous ICD system if a list of 1 suitable vectors is present in all body positions during screening. Automated conclusions of a pre-implantation screening from the manufacturer's programmers show examples of both positive and negative screening. The left image shows a positive results for all vectors in all body positions, while the right image shows criteria for a positive screening not met. As 7% or 15% of patients do not pass the pre-implantation screening, our work investigates potential predictors of negative outcome. Our data shows what a height over 180 centimeters and a QRS complex duration of more than 134 milliseconds influences the negative result of the pre-implantation screening. The prospective study included 95 individuals who were subsequently divided into subcutaneous ICD and compares transvenous ICD group. Patients did not differ in major clinical and demographic indicators at the time of inclusion in the study. Transvenous ICD were implantable using standard technique under local anesthesia. All patients with subcutaneous devices were implanted under endotracheal anesthesia. After preparing, the operator filed an incision parallel to the inframammary fold is made 2 centimeters above the antiseptic device location, and a pocket for the pulse generation is created between the latissimus dorsi and serratus anterior muscles. Subsequently, the implantation of the subcutaneous electrode is performed using a 2 or 3 incision technique. The 3 mm diameter system electrode is capable of both recording ECG and delivering a defibrillation impulse is a tripole consisting of 3 electrodes. The generator's body itself, the distal pole of the electrode tip, and the proximal pole located approximately 8 centimeters from the tip. In our study, only the first 7 patients underwent the 3 incision technique, while the remaining 45 patients in the subcutaneous ICD group received the 2 incision method. This allowed for the reduction in operative time and small cosmetic defects. At the end of the operation, the airing of the vertical tunnel is performed using a debake needle, followed by a control fluoroscopy to assess electrode position. Comparing intraoperative indication for the implantation of subcutaneous and transvenous device, a statistical difference was not in the duration of the procedure. Fluoroscopy time and radion exposure were significantly low in the subcutaneous ICD group. Position of the subcutaneous electrodes is simpler and does not require prolonged radiographic control. Additionally, a statistical difference was observed in shock impedance due to the extracardiac location of the subcutaneous electrode, requiring a higher discharge for defibrillation. All patients with subcutaneous devices underwent defibrillation testing at the end of the operation. Induction of ventricular fibrillation is conducted on sync of 200 milliamperes and 50 Hz alternating current pulse for 4 seconds. The detection rate is lowered to a minimum of 177 beats per minute. The energy of the first discharge is programmed at 65 joules. In case of the first shocks, in effectiveness, the second discharge is automatically programmed to the maximum possible energy of 8 joules with reverse polarity. In ventricular arrhythmia is not recognized by the device, or if the discharge delivered by the subcutaneous device do not result in conversion to the original rhythm, such therapy is deemed ineffective with the subcutaneous ICD system, requiring external defibrillation as shown in the endogram. In case of ineffective fibrillation testing, reposition of the subcutaneous lead or post-generation may be necessary. The time from indication to terminal of VF should normally not exceed 23 seconds, and the discharge impedance should remain within the range of 25 to 100 ohms. One of the indicators of subcutaneous ICD efficacy is the conversion of ventricular arrhythmias back to the original rhythm. A positive DFT predicts the ICD success in delivering adequate therapy. Most significant studies have reported results of arrhythmia termination using subcutaneous ICD during DFT with promising figures. Our data also aligned with the most significant global research. However, it should be noted that not all patients underwent DFT, as those with detected left atrial thrombosis did not undergo defibrillation testing. Additionally, in 3 cases, a positive result of defibrillation testing was achieved only after changing polarity or manually adjusting the sensitive factors. There were no intraoperative complications in our study. During the observation period, 1 death was registered in the group of subcutaneous device. The cause of death was complication from viral pneumonia. Complication in the hospital setting occurred in 2 patients in the subcutaneous ICD group. On the 5th day post-implantation, a hematoma formed at the device site in these patients, requiring puncture intervention. In the long term, 2 patients in the subcutaneous ICD group required rehospitalization for revision of the subcutaneous systems. One of these patients was diagnosed with serum at the device site. The other patients was hospitalization for fistulous tract in Cystopodia area. Followed by separation of the device bed. The subcutaneous ICD system was completely removed in the case. In the transvenous ICD group, one patient diagnosed with dilated cardiomyopathy was hospitalized 4 months later due to decompensation, heart failure, and several tricuspid valve insufficiency caused by obstruction of the anterior left closure by the ventricular electrode. The transvenous ICD was replaced with a subcutaneous device. These complications were somewhat higher in the patient with implantable subcutaneous ICD. In the subcutaneous ICD group, nearly all inappropriate shocks were due to an increase in heart rate up to 200 BPM in patients with persistent atrial fibrillation. These patients underwent adjustments of the device settings. The conditional shock zone was increased to 220 BPM, the shock zone to 240 BPM, and anti-tachycardia therapy was intensified. One of the inappropriate shocks was due to electrode dislocation. In this patient, the device activation occurred while playing an electric guitar. Examination of the electrocardiograms prior to shock showed wide QRS complex wiring duration and amplitude. Thus, the device activation was due to male potential detected by the device as ventricular tachycardia. A reposition on the subcutaneous electrodes was performed for these patients. The delivery of operated shocks can be seen as an indication of the effectiveness of the Cardioverter-Defibrillation. The presented electrocardiogram shows an episode of stable ventricular tachycardia with successful conversion of the original rhythm. The low electrogram shows unresolved episode. The original rate resumed spontaneously. A shock was not delivered, as the number of complexes with ventricular tachycardia was less than required for a shock according to the algorithm. Over the past year, 13.4% of patients with subcutaneous ICD and 22% of patients with transvenous ICD received appropriate therapy. Thus, the proportion of adequate shock therapy was higher in the transvenous ICD group. Likely, this was because the subcutaneous defibrillator takes longer to recognize arrhythmias and charge the device, results in average time to therapy of 20 seconds. This delay could lead to spontaneous termination of unstable tachycardia episodes. Inappropriate shocks were registered at 11% for subcutaneous ICD and 11% for transvenous ICD over a year with no statistic difference. According to our results, the implantation of device, both subcutaneous and transvenous, improves the quality of life of patients, as confirmed by questionnaire results before the after interventions. This result demonstrates what the dynamics of quality of life parameters in patients with subcutaneous and transvenous ICD are comparable, and implantation of any system improves patients' quality of life in the short term. The effectiveness and safety of subcutaneous ICD are evaluated based on the delivery of appropriate and inappropriate shocks. Our data correspond to the most significant global studies conducted with subcutaneous ICD. Thanks for your attention.